Okay. Dear honorable chairs, distinguished colleagues, I'm Dr. Peng Jianzhong from Hangzhou Third People's Hospital, China. Today, I'm honored to present our clinical study on mandibular keloids therapy for the challenging mandibular keloids. This didn't work. Oh, okay. Okay, thanks. This presentation is structured into 5 core sections. First, we will briefly discuss the clinical challenges of mandibular keloids and the principles of photodynamic therapy. Next, we detail the studies, the materials, and the methodology. We then present the key results, discuss our clinical implication, and conclude with a summary and future research directions. Our study focused on mandibular keloids. These often arise from severe acne in adolescent patients. This mandible is a high tension anatomic site. Recurrent scan drives chronic inflammations, rendering this scar recalcitrant to standard treatment. Current management include conservative modalities, injections, physical therapies, lasers, and surgical excision, radiotherapy. However, all have significant limitations. Conservative therapies often fail in several cases. Surgery alone has high recurrence rates, and the surgery plus radiotherapy is invasive with notable adverse effects. This highlights the urgent need for innovative therapeutic strategies. We know photodynamic therapy, PDT, is a minimally invasive modality using light activate photosensitizers to induce target cell death. The protocol involves topical photosensitizers application, followed by light activation to generate reactive oxygen species and induce cytotoxicity. PDT shows promise in scar management by mandibular collagen remodeling and reducing neovascularization. Nevertheless, when PDT is applied to scars, it presents a significant limitation, namely poor penetration. The dense collagenous structure function as a barrier, impeding the drug and the light from reaching the target cell located deep within the scar tissue. This gave rise to our core inquiry. How can this barrier be surmounted? Our hypothesis posted that creation of microchannels in the scar tissue could augment drug delivery and render PDT more efficacious. To validate our hypothesis, a prospective clinical investigation was designed and conducted at Hangzhou Third People's Hospital. The primary aim was to assess the safety and the efficacy of combination of the mini punch technique and the PDT in the treatment of mandibular keloids. Patients with mandibular keloids who had not undergone any treatment for a minimum of 6 months were recruited. Patients with active infections, connective tissue disease, or allergies to photosensitizer were excluded. The study was approved by the ethics committee, and all patients provided their informed consent. The mini punch technique entails the utilization of a small electric fan to form microchannels within the scar under local anesthesia. Vertical punching is performed to excise core of scar tissue, followed by oblique punching to generate a honeycomb pattern. This approach not only eliminates a certain amount of scar tissue, but also establishes pathway for the PDT drug. When 20 hours subsequent to the mini punch procedure, the photosensitizer 20% 5-amino-navalinic acid was directly administered into the microchannels. Following a 4 hours incubation interval, the area was irradiated with 635 nanometers red laser under specific parameters. The enteral photosensitizer therapy (PDT) process was replicated on the weekly basis for a total of these sessions. To assess efficacy, the VSS was employed as the primary objective management. This scale evaluates symptoms, sickness, pliability, pigmentation, and vascularity. A lower score indicates a superior scar condition. Additional, a 5-point score was utilized to enable patients to subjectively rate their improvement. Presently, let's examine the outcomes. A total of 20 patients was recruited with an average age of 26 years. In aggregate, 40 lesions were treated, which were either dispersed or coalesced into large patches. Objective, a notable improvement was observed. The mean VSS score decreased from 9.6 prior to treatment to 4.15 at 12 months follow-up. This difference was statistically highly significant, with a p-value of less than 0.01, suggesting the efficacy of the therapy. Subjective. Patient feedback was highly positive. 60% of lesions showed excellent improvement. 50% showed good improvement, and 75% demonstrating greater than 50% improvement overall. Suboptimal outcomes were limited to extremely sick lesions, suggesting multiple treatment courses may be required for such cases. We can see the case presentation. 24 years old male with jaw keloid underwent mini punch excision followed by 3 sessions of PDT. At 12 months follow-up, the scar demonstrates significant flattening and reduced erythema, achieving an excellent therapeutic outcome. This is the case 2. This is the case 3. The older patients demonstrate notable flattening, diminished glycemia, and remarkable cosmetic enhancement 12 to 18 months after treatment. These cases confirm the clinical feasibility and effectiveness of the combined approach. Let me see the safety profile. The therapy was well tolerated. Common adverse events included transient swelling and pain, which were manageable. Ulceration occurred in some cases, likely due to overly dense hole placement. Importantly, all wounds healed without infection, and the pigmentation changes reversed over time. With proper technique, the procedure is safe with manageable side effects. Therefore, the remarkable efficacy of this combination therapy stems from a synergistic mechanism. Mini-punch addresses a key limitation of PDT by creating channels for deeper drug penetration, while physically reducing scar volume and disrupting mutations to enhance tissue responsiveness to subsequent PDT. Based on our empirical finding, several critical factors determine treatment success. Optimal punch hole spacing of approximately 2 millimeters is recommended. PDT within 24 hours is key to preventing regrowth. Selecting trephine size based on lesion thickness and using post-treatment compression masks are also essential for optimal outcomes. When comparing a combined therapy with other alternatives, is often distinct. Advantage is minimally invasive, which low trauma and mild side effects, unlike surgery combined with radiotherapy, which is highly invasive and associated with significant self-effect. Unlike PDT used alone, our approach achieves excellent drug penetration. Moreover, it's repeatable and has no age limitations, making it a versatile choice. In summary, our therapy presents a highly efficacious, minimally invasive, and safe treatment modality for diverse scar types. Key advantages include repeatable administration and, most significantly, eligibility for pediatric and adolescent patients who cannot undergo radiotherapy is very important, addressing a critical unmet need in current scar management. We also analyze cases with suboptimal outcomes or correlate with excessive sickness. Notably, repeating treatment after a 6 months interval yielded favorable results in these patients. This indicates that while our therapy demonstrates excellent efficacy for flat lesions, very thick lesions may require multiple treatment sessions. It's crucial to acknowledge the limitations of our study. Notably, our sample size was relatively modest, with a follow-up period extending to 18 months. Most significantly, this was a prospective study without a control group. Future randomized controlled trials will be essential to provide a higher level of evidence regarding the efficacy of this treatment. Looking ahead, our research will focus on 3 key areas. First, conducting randomized controlled trials to directly compare our approach with existing treatment. Second, optimizing treatment parameters and conducting long-term follow-up studies to evaluate treatment durability. And the third, exploring the application of this therapy for scars in other anatomical regions. In summary, our research demonstrates that combining the mini punch technique with PDT constitutes a cell and effective therapeutic approach for mandibular keloids. By enhancing drug penetration, this minimally invasive strategy achieves significant clinical important improvement with a favorable safe profile. It offers a promising novel treatment option for patients with this recalcitrant scar. Our central finding demonstrates that a novel paradigm has emerged. The integration of physical method to bridge the scar barrier with a biological treatment leads to robust synergistic therapeutic effects. This enables the attainment of remarkable outcome with minimal invasiveness, unlocking no therapeutic avenues for patients afflicted by disfiguring scars. Looking ahead, the study lays a robust foundation for future investigations. We hypothesize that through large-scale trials, the therapy was emerge as a standard treatment for the pathological scar. The continuous optimization of the technique could facilitate even more favorable results and broad applications. Okay, thank you. Thank you for your attention.
Do we have any questions for Dr. Peng? Up here first. I saw that one first.
Yeah, so thank you. I think the approach of PDT is interesting. Of course, the penetration is the big limitation, both of the drug, maybe also of the light, depending on the source of light and the wavelengths they're using. So that was red light, which should go deeper. But actually, I was thinking, do you really need punches of 2 millimeters in diameter? Because if you think about laser-assisted drug delivery, and PDT is one of the applications. So the fractional laser-assisted PDT, there are at least 10 nice randomized controlled trials, and certainly more than 30 trials out there on PDT, which is potentiated by a fractional laser. And the holes then of those lasers are something like 120 to 200 micrometer in diameter. So that's 10 times smaller. So this would really be micro-invasive treatment without any visible wound. I just wonder, would that maybe also work, even being less invasive? But I think it's a very interesting concept.
Okay. As we all know, no treatment can completely kill keloids. We are considered a chronic condition required a long-term management. Propose a new method to repeatable and has no side effect. Through PDT is not as strong as radiotherapy, but we can offer a new method for the children and the adolescent under age of 18 who are not eligible for radiotherapy.
Okay, well, thank you very much. I think very interesting approach. Why are you doing the PDT 3 times? You only punching the holes once, then you do the PDT for the first time, and then you're redoing it 1 week later and another week later. So very little of the molecule is then going into the scar, I guess, if the holes are already closed.
I can use the PDT. Sorry. Okay.
Did you understand the question?
Can you repeat your question, Rob?
The protocol, from what I understood, is 3 times PDT, 3 cycles, and you only do the holes once. You're not doing the holes 3 times. So it's at the beginning, punching the holes, first PDT, again 1 week later, again 2 weeks later.
Mini punch just once.
Yeah.
And the PDT 3 sessions
So
of the week and a week.
why 3 sessions? Why don't you only do 1?
If it's useful, I can do it again.
Have you tried only once?
Try to do 3 months later, do the second.
Okay, but penetration is not going to be good if the holes are closed.
Thank you. Maybe I can make a little bit complimentary. So for the first question, I think on one hand, it's a kind of invasive, like small holes. We can use laser. Okay, we can use even smaller punch diameter. But in the same time, actually, when we use the like 2 millimeters or 3 or 4, we found it also cause that we can reduce the volume together, in the same time. So I think that's why, because for me, if it's from the chest keloids, I will choose like even 4 or 6 millimeters. So maybe that's one. That's why.
I understand indeed, if it is bulky, you want to also reduce the volume, but some of the scars were not that bulky. So when they're rather flat, I could imagine that volume reduction is maybe not the major goal, but it depends.
You're very right. If it's quite flat, I will just make some complimentary. If it's quite flat, so and if it's not too red, actually maybe we go to the second question. We will make only once or twice of the PDT. Not really. We need 3 or even more. So normally we use PDT every week, once every week. For this one, mandibular keloids, because it's a kind still a little bit thick, so we need like 3 or 4 weeks to repair. And during those days, you still have the wounds, and it's easy to penetrate. And also, because the scar was still there, so usually we do once a week. Normally 3 weeks, but actually sometimes it's especially for those very red and with quite severe, still what we call not stable acne. So we sometimes use 2 process means that even 6 PDT. I did like this.
It's very expensive.
And not that.
We
Not that
did
expensive.
3 times. Just we focus the mandibular keloids because it's not a very thickness.
Cream, we used the, I don't think we were using cream. We used the fluids. I mean, yeah.
Okay.
Yeah, maybe when you have larger punches, it's not yet healed after 1 week, and you still have a larger penetration.
Sentence, yeah.
I think it's self-made, it's cheaper.
No, it's commercialized. It's a kind of Chinese product. I think that's the only ones in the world, international one. So it's not that expensive. Look, because our surgery procedure is quite cheap actually. So for that one, I think maybe
Oh, you
it
got it,
took
okay.
1,000, not more than 1,000, because it's 500 per per injection. So if double size is 1,000 Chinese yuan, not euros, it means that it's only 1/8 of the cost. Yeah.
Thanks.
Yeah. Not
Any other
much.
questions for Professor Peng?
Video therapy, even less. Yeah.
Thank you very much. Any other questions for Professor Peng? If not, thank you very much. And we start the next session. Dorothy, you're chairing the session.